Hi, everybody. Welcome to today's webinar. Today's webinar is going to be on the benefits of orthotopic models. My name is Lax. I will be your host for today. Let me go over a couple of technical pieces here, and then I will introduce our speaker, Dr. Grass, and I'll hand the floor over to Dr. Grass for the presentation. A copy of the presentation will be available after the webinar is completed. If you have any technical difficulties, please raise your hand in the control panel and our technical staff will assist you. If you would like to ask a question, please use the Q&A tab in the control panel and send your questions to our panelists. You can choose it from the drop-down menu there and send it to our panelists. At any point in time during the presentations, if you want to get back to the control panel, you can click on the blue button on the floating panel at the top, and that will get you to the control panel. So let me start by introducing our speaker for today, Dr. Grass. He received his doctorate from Columbia University in molecular virology. He did his postdoctoral training at the Sloan Kettering Institute for Cancer, working with Dr. Elizabeth Lacey in molecular immunology. He joined Taconic in 1992 as a senior scientist and was responsible for establishing a transgenic animal model generation service. He also supervised research aimed at generation of rodent models for inflammatory conditions and human lipoprotein metabolism. Over the past decade, he has authored and co-authored several peer-reviewed publications. He was instrumental in creating our phenotyping platform used for characterizing more than 200 knockout lines and over 400 compounds. He's currently our VP of Business Development. And without further ado, I would turn the floor over to Dr. Grass. Dave?
Thanks, Lex. I'm happy to be able to speak to everybody today about the benefits of orthotopic models. Before I get started, let me just talk a little bit about just Taconic for those of you who don't know, and what our goal is at Taconic. Taconic is a life sciences company that facilitates biomedical research. We do that by providing access to animals, that's traditional strains, transgenic animals, and by creating custom genetically modified animals as well, and included here are immunodeficients that you might use for oncology studies. In addition, we can generate cohorts for your studies at a defined health status, and as Lax was referring to, we do contract research, so we provide data from those animals, either genetically modified animals that we're phenotyping, or we can do compound profiling. We cover most of the major therapeutic areas. Our goal is to be able to combine access to innovative models with the characterization to create more predictive preclinical data. Today, I'm going to focus on what we're doing in the area of oncology. And we've put together a platform, a portfolio that we're calling T-Onco. We're doing this in partnership with a collaborator, OncoDesign, and we're bringing a lot of different things together in this portfolio, including sophisticated imaging techniques, patient-derived tumors. We're working also with CIEA from Japan. We have access to a super immunodeficient mouse called NOG. We also are working with the National Cancer Institute in the Netherlands to have spontaneous tumor models, and we're creating orthotopic allograft models from those mice as well. So we have a lot of different ways that we can help people working in oncology. Today, my focus is going to be on orthotopic models, and I'll show you some of what we can do with that and the value of doing that. Most of these are going to be xenograft models. And we think we were interested in getting into this many years ago because we think they're more representative of human cancer with respect to the primary tumor location and the pattern of metastasis. There are several challenges in that you need technically skilled staff to be able to do the surgeries, to implant the tumors, and I should mention that orthotopic, for I'm sure most of you know, means that we're implanting the actual tumor cells at the tissue where the tumor originated. So you need technically skilled staff to do those types of surgery, and we take advantage of a technology, bioluminescent imaging, that was developed by Xenogen Corporation, and I should mention that our group, before we were part of Taconic, was part of Xenogen, who developed that technology. Caliper now distributes these imaging instruments. We are using, to do these studies, we are using cell lines that have been modified to express luciferase. And we're covering many of the major cancers, so breast cancer, ovarian, prostate, lung, colorectal, brain, melanoma, and pancreatic at this point. In addition, we can custom create cell lines, meaning that we can take cell lines and transfect luciferase in so that we can use this imaging technology in order to do these studies. On this slide, it talks about standard BioAir and BioAir Ultra. The difference, they differ only in the specific luciferase sequence that the cells have been modified with. Luciferase 2 has been codon optimized for expression in mammalian cells. However, we've used a lot of these cells with luciferase 1, and we have good sensitivity doing studies with them. So I want to talk a little bit about, in general, how we do these orthotopic tumor models with spontaneous metastases. And this first slide shows you 3 different examples of tumors that were implanted. PC3M for prostate, in the prostate, MDA231 in the mammary fat pads, and the SCOV3 in the ovary. And you can see that in all the cases, we're following now one mouse, and what we're looking at here is a false color image where red represents the highest density of photons being emitted from the animal, and blue represents the lowest density on the scale that we have right now. So you can see that the tumors are growing over time in all the cases. In addition, you can see that for this breast cancer tumor, there is a section that is coming up in the false color image blue, surrounded by red, indicating that this may be a necrotic core in that particular tumor. So there is information that you can get from doing this imaging that you might not see just by doing caliper measurements. Now, if you block the light from the primary tumor, and what we're showing here is that this, I don't know what to call it actually, this kilt, if you put it on the mouse, it blocks the light from the primary tumor, and then we're able to see if there's light coming from other areas in the animal, in vivo, in the live animal. And you can see that in the prostate tumor model, we can see that there's light coming from above where the opaque material is. Same for the breast cancer model, same for the ovarian, indicating that the tumor cells have metastasized. And in this example here with SCOV3, this is the ovarian tumor, you can see that if you look at the brain, the lungs, the liver, the lymph nodes of the GI, the bones and the muscle, and then you image them, you can see that there's light coming from these tissues, indicating that cells have metastasized to these different tissues. And I should mention that in order to do ex vivo imaging, you have to work very precisely, very quickly, because luciferase requires ATP. The cells have to still be alive. So when you do the necropsy, you have to work quickly to be able to do this. If you do that, you can get pretty tight data, and I'll show you some examples of that later on in the presentation. So now I want to show you a breast cancer model and show you that we can use what happens when we use a reference compound with this model. So this is the MDA-231 transfected with luciferase. You can see on the left side, and I should mention that we're using Taxotere, which is docetaxel, as our reference compound. And we're comparing on the left side of the slide and the right side of the slide the data that we get from caliper measurements, which we can do for breast cancer, and the data that we get from the bioluminescent imaging. And you can see that the data is, you get a similar pattern, basically. The imaging system allows you to select a region of, that you, where we can focus and see whether the photons are coming from there, a region of interest. And you can see here that by photons per second or by fold change, if we focus on the chest area, the vehicle-treated animal, we see an increase in bioluminescence over time, whereas the docetaxel-treated group, we actually don't see an increase, and that's both with photons per second and with fold change. We're seeing similar data there. If we look over time, so before treatment, 3 days post-treatment, 6 days post-treatment, 10 days, 13, and we're looking now again at the region of interest, the chest area, you can see that as time goes by, we start seeing an increase in light coming from the vehicle-treated animals, and the docetaxel-treated animals, we remain down at baseline. So you can use this technology to look at metastases in vivo. Again, looking at all of the different animals in the group now, ex vivo, the lungs and the lymph nodes. Vehicle-treated group, you can see that there's bioluminescence from a majority of the mice. Same thing from the lymph nodes. The docetaxel-treated group, I think there's some photons coming here, but by and large, we're not seeing any photons in this group. And you can see that there's a significant difference in terms of the bioluminescence, looking at this scatter graph, in the vehicle-treated lungs versus the compound-treated, and also in the vehicle-treated lymph nodes versus the compound-treated. And you can see these three didn't have metastatic events there. MCF is another breast cancer line. This is estrogen receptor positive. The MDA is estrogen receptor negative. Again, looking at the primary tumor over time, you can see that there's significant growth. And you can see here we're just looking at the lungs and also the lymph node, that we do get metastatic events from this cell line as well. The breast cancer lines that are currently available that we work with are the MDAs, MCS7, and we're currently developing BT474 cells. In addition, we have a mouse allograft tumor model. This is not a light-producing model. That's P53 negative, BRCA1 negative. I'm going to show some data on prostate cancer right now, PC3M. Representative animal in the vehicle-treated group, you can see that the tumor grows over a period of time. The animals treated with Taxotere, you can see that there's not that much bioluminescence, and by day 36, we're actually not seeing any. And that's represented in this graph on the left side of the slide here, where the vehicle treated, you see increasing light. The Taxotere treated, you actually see a decrease. On the right side of the slide, we're comparing the bioluminescence from the primary tumor with the bioluminescence from the distant metastases. And you can see that there's several orders of magnitude different, and that really in order to see it, you have to block the light from the primary tumor, just similar in the sense that when you are outside at night, you get to see the stars because the sun is not shining. Ex vivo imaging of the lungs, liver, lymph node. You can see the scatter graphs over here. At the end of the study, this is for PC3M. And you can see that we have significant light in the we have significant light coming from the vehicle-treated group in all cases, and only in a couple of animals do we have significant light coming from the docetaxel-treated group, and those images are actually here. So these are the vehicle-treated lungs, liver, lymph nodes of the GI, and the docetaxel-treated. You can see that one lung is lighting up, a couple of different livers are lighting up, and a couple of different GIs in the docetaxel-treated group, but certainly not the same amount of light is coming from the vehicle-treated group. Another example is SCOVE-3. In this case, we're using paclitaxel or Taxol. You can see that the vehicle treated, we're getting a lot more light coming out compared to the drug treated. When we look at the metastases, we see a similar pattern where we actually see a lot more light coming from the vehicle treated compared to the paclitaxel or Taxol treated. Ex vivo imaging, 5 different tissues. You can see the lungs, liver, GI of the lymph node, hind limbs, which would be muscle, and brain. And you can see that we get different bioluminescence or photons per second when you compare different tissues. But in all cases, the Taxol treated has significantly lower bioluminescence. Pancreatic cancer, now we're doing docetaxel again, or Taxotere. And you can see a representative animal vehicle treated. The tumor is growing in the pancreas. Taxotere treated, we get much less growth. That's graphed on the right side of the slide here. Looking at metastases at the end of the study, again, various different tissues, you can see a significant difference in terms of the light that we're seeing from lungs, vehicle treated versus Taxotere, liver, same, spleen, and you can see that all graphed on the right side here. Last example is brain U87 luciferase model. We used irinotecan, 20 mg per kg or 40 mg per kg. We do get a significant reduction in light coming out, photons per second, at the 40 mg per kg. These are what the images look like. Again, more light coming from the vehicle treated compared with the high dose. And we also have a difference in animal survival rate when we compare the vehicle treated and the high dose. So to summarize, we've developed a lot of different orthotopic models. We can run these as sub-Q models as well, but we think that we get more information and better information from the orthotopic. We've been able to show that we have spontaneous metastases in most of these models. We also do have the capabilities of doing experimental metastatic models, either IV or intracardiac injection. And the last point, and this is the last slide, the last point I want to make, which illustrates some of the value of doing these orthotopic models and looking at spontaneous metastases, is that this slide on the left side shows the frequency of metastatic events in human breast cancer patients. On the right side, it shows prostate cancer patients. The red asterisk shows the tissues where we've seen spontaneous metastatic events in our models. And you can see that we are seeing these events in all of the major, in most of the major tissues that you see it in the, that we've looked at compared to what you see in the clinic. So because we're placing these cells orthotopically, because they have access to the lymph and the blood flow the same way that they would from the tissue that the tumor originated, we're seeing metastatic events that are similar to what you see in the clinic, both in the breast and in the prostate. And I think that's one of the important values of this type of technology, which we think is really useful for screening compounds. It's a fairly high throughput technology that allows us to screen through a number of compounds quickly. And then, as I was pointing out earlier in the talk, there's access to more sophisticated technologies through T-Onco that can do a deeper dive. You can look at patient-derived tumor samples and things like that, where the throughput may not be basically as high. So I want to thank you for your attention today, and we can answer or try to answer any questions that you may have.
Thanks, Dave. We have a question in here from a participant. Are orthotopic models better predictors of drug efficacy compared to sub-Q models?
I would say that in general, there's certainly, it depends on what you're studying. In general, they're good predictors. If you have a negative result, I think that you're not hitting your target or something's happening to your compound and it's being metabolized. But also, a lot of groups are now focusing on trying to block metastatic events. And I think that the orthotopic models are certainly much better than sub-Q for that kind of study. And when you think about it, the treatment of cancer in general, the treatment of the primary tumors generally to resect it, and it's the metastatic events that really are harmful. So I think that that's where this orthotopic technology is really helpful.
We have another question here. Can you detect circulating tumor cells with orthotopic versus sub-Q?
Yeah, I think that orthotopic is, as I was saying to answer the last question, you're much more likely to get metastatic events with the orthotopic than with sub-Q. So, and I think that based on the data that I was showing, we are getting metastatic events in a large fraction for the different models that we've developed at this point.
Thanks, Dave. Another question here. If one wants to create an orthotopic pancreatic cancer model, how long does it take to master the surgical capabilities required to do a model like that?
I would say that you're probably looking, it depends on how intensively you're doing it if you're practicing every day, but you're probably looking at probably a couple of months to master the surgeries if you're good at the surgeries. The other thing I should point out is that every pancreatic cell line may not have the same metastatic potential, and we've basically screened screened for cell lines that have significant metastatic potential. So that's something to keep in mind as you're developing these types of models. We've passaged them. I should mention that we've passaged them in vivo to get cell lines that actually have a good metastatic potential.
Thanks, Dave. I have another question here. It refers to measuring analytes. So it's asking, does Taconic have the capability to measure analytes like cytokines or hormones as part of an orthotopic model's readout?
We can certainly measure analytes. We do have the capabilities. We have a pretty robust inflammation and also metabolism program. But I would point out on this that for a lot of the models that I showed, most of the ones are xenografts and are being run on immunodeficient animals. So you're not going to get the same information looking at cytokines. Now, we do have some allograft models that we've developed, a couple of breast cancer models actually, where we would be running those in a syngeneic immunocompetent animal, and we can certainly do those types of readouts in those models.
We have another question here. Have you examined the stroma and detected any differences compared to sub-Q implanted tumors?
We have not looked at that specifically. So no, we have not looked at that specifically in terms of the stroma. No.
Okay. I think we have another question here. Have you compared syngeneic models in immunodeficient and immunocompetent animals?
We have actually done that, and we did it for a different reason, really. We were trying to see if we could get a bioluminescent cell line that was to run in an allograft model, and we did find that at least in one strain that we were working in, that we may have been getting a little bit of an immune response to the luciferase. So we did run that in an immunodeficient animal, and it did grow better. In general, without the luciferase there, we don't have a lot of experience doing that. I don't think that there's I think we've done it once. I don't think there was a significant difference in terms of the immunodeficient versus the immunocompetent.
Another question here. Can you surgically remove the orthotopically implanted tumors, thus by doing debulking?
Yeah, we can, and actually we've done that. We've done that on some of the studies that for sponsors. Specifically, I have it in. I can remember that we've done it for the breast cancer, where we've actually removed the primary tumor and then studied what happened to the metastatic events.
I think another question here. You provided a list of the cell lines that are available at Taconic. Is this list available by any chance on Taconics' website?
I think it is available on Taconics' website.
Yeah. You're right, Dave. It is available.
Okay.
Yeah.
Thanks, Lex.
Yeah. I think we have one last question here. Can you create a you said you can create a bioluminescent cell line at Taconic. How long does it take to create a bioluminescent cell line?
I would say that it's going to take approximately, it's 1 to 2 months. But what you have to keep in mind is that there should be, normally when we do it for ourselves, for a cell line that we're going to use repeatedly, then after we create it, we do significant validation. So we look at the growth characteristics, both in vitro and in vivo, and that takes a few more months, basically, two more months, let's say, to do well, so that we know that we want to make sure that the cell line is not significantly different from the parental.
Another question here: do you look for circulating tumor cells in your models?
Circulating tumor cells, meaning at this point like leukemias or?
Not quite sure what they
because
mean.
I can answer that and say that we haven't done a lot of that, but we do have FACS capabilities, which would allow us to really look for circulating tumor cells. Imaging in vivo, depending on the bulk of cells, would be difficult to look at circulating cells, as they circulate. Is that answer clear?
Yeah. And
okay.
I have another one here. How do you distinguish leaking tumor cells from metastases in your orthotopic mouse models?
That's a good question. And it's a little bit of a difficult one to answer because we don't have, I was going to say, we don't have, when we do the surgeries, basically, we can determine where the cells are. We don't think that there's leakiness, but it's hard to know that a cell hasn't escaped. So that's a difficult one for me to answer at this point.
All right. Thank you very much, Dave. I think there are no further questions. Thank you, everybody, for attending today's webinar. Stay tuned for more webinars at www.taconic.com/webinars. And I thank everybody and the presenter for presenting the webinar today, and thanks for attending. We hope to